I'm Rouka. I'm the technical advisor for the National Health Information System, and I provide technical advice in relation to the National Health Information System in Papua New Guinea.
My name is Charlotte Potty. I'm the statistician for discharges for inpatients. I directly report to ILA, and I'm in charge of deaths, MCCODs, and verbal autopsy. I mean, it directly comes under my section. Maybe 85% of our deaths are not reported. Only 15% are reported through the health system. So the VA should, or we would like it to be able to help us collect the 85 unreported deaths in the community. A lot of deaths are not reported in PNG, mainly because some generally might not think it's important. They just let it go. They would have deaths and they would just have a house cry, they'd call, and then bury the dead, and they would not register. You have funeral services, but we have a bit of a mourning period where we have family and friends who come to mourn the loss, and then some may range for like a week or some others 2 weeks. Then so sometimes you may see that, but they may not have it recorded on a piece of paper like the medical death certificate. So we would hope that VA would capture those unnotified deaths.
One of the reasons why some deaths are not reported is because some of these villages are very remote, they're inaccessible.
I think currently, because health is way advanced with information, we have over 700 health facilities reporting in PNG to the National Department of Health. So we have received deaths, notifications, and birth, maybe through hospitals. We have monthly reports, but we're not quite integrated yet. Right now we are in the, I think, just initial stages of bringing the responsible arms together to create that one system. Now it's just us. I think we are leading the way for everyone else.
One of the important plans is, once if more than 500 VAs are collected, what we will do is, once the VA data is analyzed, we will have to provide reports to our CRBS committee. We have a CRBS committee already in place, and so we will have to provide to our National Burden of Disease Committee to inform policy decisions. We had a fellowship in Melbourne Uni last year, from October to December. We had a mortality coding training in around March in 2017, and due to the responsibilities given to me, I was not doing mortality coding. So I forgot the concept that I learned because I was not coding. Because of that fellowship, I was able to code again. Well, mortality coding is very important because according to the quality assessment that we did, out of the 633 death certificates that we have assessed, 98% of the death certificates were incorrectly filled in. When we got back to our country after the fellowship, I was used as one of the facilitators in MCCOD's trainings. I presented to them the quality assessment that we did, especially the common errors that they do in completing the death certificates. To be honest, the quality has slightly changed. During the fellowship program, we have only assessed 633 death certificates. Now we have assessed between 800 to 1,000 certificates, and we have trained around 400 plus medical officers. So looking at the number of certificates and the quality assessment that we did, it's slightly changed. After the MCCOD's training, we expect doctors to fill in the death certificates correctly, so that they can be able to provide us better information to make better decisions. If we make better decisions based on better information, then this will lead to better health for Papua New Guineans. So better information, better decisions, better health for Papua New Guineans.